Hi, everyone, and thank you for joining us today for our second Community of Practice Lunch and Learn webinar. My name is Nicole Hamame, and I'm a project coordinator at the Center for Behavioral Health and Justice, which is a community-based research center that provides local communities, organizations, and behavioral health and law enforcement agencies across Michigan with technical assistance, evaluation, and support to optimize diversion of individuals from jail and prison through the implementation of best and innovative practices at every intercept of the criminal justice continuum. This webinar is part of our Opioid Treatment Ecosystem Initiative, which is a technical assistance framework aimed at strengthening community-based substance use disorder treatment at the intersection of criminal legal systems. Through this framework, the CBHJ has convened county-level change teams that feed into a larger community of practice, including all of you who have joined us here today. Collectively, this community of practice is working to provide life-saving medications for opioid use disorder in jails, ensure continuity of care to prevent overdose upon release from jail, and connect first responder and behavioral health systems to increase community-based treatment access. Today's event, and those we hold in the future, will be focused on sharing new ideas, addressing common barriers, and allowing for discussion to encourage expansion, enhancement, and sustainability of county-level treatment ecosystems. Generous support from the Michigan Health Endowment Fund has made it possible for us to offer this event as part of the OTE community of practice. Before we get started today, we have a few housekeeping items to share. Your audio and visual capabilities have been turned off to limit distractions throughout the presentation, but we do encourage you to ask questions of the presenters, and we'll provide the opportunity to use your microphone to do so toward the end of the event today. If you've joined us on your computer, you can click the raise hand button on your screen to indicate that you'd like to ask a question. If you've joined us by phone, press *9 to raise your hand. When it's time for Q&A, our team will call upon and unmute you in the order that hands were raised. Please be prepared to ask your question and keep it as brief as possible to allow us to get through as many questions as we can. If your question has already been answered, please click the lower hand button to remove yourself from the queue. And if you'd like to ask a question but don't feel comfortable doing so live, you can enter your question in the Q&A box on your screen. We'll address the live questions first, and then we'll move on to written questions if we have time. So the topic of today's webinar is on the life-saving medication called naloxone, also commonly known as Narcan, which we believe is a necessary component of a comprehensive treatment ecosystem. To help us understand how naloxone works to safely reverse the effects of an opioid overdose, we will first hear from Jessica Moreno, a psychiatric clinical pharmacist at Beaumont Health, providing psychiatric medication evaluation and medication management for primary care patients. She also works on grants and initiatives focused on improving the care for patients with substance use disorders at Beaumont. Prior to her current position, she was a clinical faculty member at Northeastern University in Boston, and her clinical practice was with the Substance Use Disorder Initiative at Massachusetts General Hospital. She is well-versed in the benefits and need for naloxone in our communities, and we are so grateful to have her here today. Jessica?
All right, thank you, Nicole, and thank you everybody for joining today. So as Nicole mentioned, I am going to be giving you just a very brief introduction into naloxone and its potential benefits. As soon as I figure out how to use this. Here we go, okay. So just to jump in, I think that it's always a good place to start with really why are we talking about this and why does this matter? I think to most people in the United States at this point, we're pretty aware that the overdose epidemic is a very serious problem, particularly now that we have a pandemic also happening at the same time. Since 1999 and up until about 2020, we had seen that opioid overdose deaths had quadrupled in that period of time. And now we're still seeing continuing rises in overdose deaths over the last year or so, even though there was a slight dip in 2018. At this point, about 128 people are dying every day by opioid overdose. And then there were a couple studies completed showing certain populations of patients who were at higher risk, and particularly the ones that are most relevant to this conversation today are people recently released from the criminal justice system. So a study done in North Carolina found that inmates who were released were at about 40 times higher likelihood to die of opioid overdose than people not recently released from jail or prison. And then in Massachusetts, that risk was actually up to 120 times more likely to die of opioid overdose. When we're talking about naloxone, we're really talking about the antidote to opioid overdose. In the field of medicine and pharmacology, we don't have a lot of substances or medications that we get to call antidotes. They really are the cure for an opioid overdose. Within the United States, we have 4 different versions available. The more common ones that we tend to see in the community are at the left side of the screen. This is what we call a naloxone kit or a Narcan kit. So you can see that there is what we call the nasal atomizer, there's a syringe, and a vial of naloxone that gets kind of twisted into that syringe for use. There is also the brand name nasal Narcan spray, which is much easier to use and really just involves the pushing of the lower plunger button. There's Ebzio, which is an injectable version of naloxone that gets injected into large muscle groups. This tends to be quite expensive and is usually only seen for amongst groups of people or healthcare systems that are able to buy and negotiate significantly with the manufacturer to be able to lower that price down. And then finally, at the top right is the kind of traditional generic injectable naloxone that is used in hospital settings, but also at the beginning of community distribution programs for naloxone, this tended to be the formulation that was given out to most people in the community that were at risk or at risk of seeing people at risk of opioid overdose. What naloxone is, as I said, it is the antidote to an opioid overdose. So in our brain, specifically in a certain area of our brain that controls our breathing, we have all of these opioid receptors. And when there is an opioid overdose, those opioid receptors are essentially overrun by opioids. And that actually tends to turn down or turn off the signals that our brain sends to our lungs so that it knows how to, so that our body knows to take breaths. And what naloxone is able to do is essentially kick those opioids off of those opioid receptors so that the brain is then able to restart sending those signals to the lungs so that our body knows to take a breath. What's nice about naloxone is how effective it is. As I said, it is the only antidote that we have for opioid overdose. Without naloxone or without pretty invasive medical interventions, 100% of people who experience opioid overdose will die if they do not have naloxone administered to them. So this is such a critical medication, and it's what I tend to refer to as the literal lowest hanging fruit that we have available to us to start making an impact on reducing people dying from opioid overdose. There have been a couple different programs conducted throughout the United States and in different states to see the kinds of impacts that increasing naloxone availability in the community can have. And Cook County in Illinois had shown about a 35% reduction in opioid overdose deaths after they were able to implement a naloxone distribution program. And then out in Massachusetts, they had implemented a community overdose education and naloxone distribution program, and they had actually found a 45% reduction in overdose death since starting that program. Something that often comes up is concerns about the safety of naloxone. In the United States, there are kind of a handful of medications that we consider safe, and those are the things that we often see over the counter that you can just walk into any pharmacy and purchase. And yet naloxone, for some not very great reasons, continues to be a prescription medication, in that a prescription is required in order to obtain naloxone unless the state has something called a standing order, in which case there's still a prescription required to obtain it. It's just that the pharmacist who's working in a specific pharmacy is able to essentially write and fill that prescription. It's a little bit of a workaround for medications that are considered completely safe and really shouldn't require any sort of prescription. So when I say completely safe, what I mean is that there are so rarely adverse events that occur with administration of naloxone. But if you're concerned about them, some of those events are things like administering naloxone might not be 100% effective. And a lot of times that happens if it has some other substances in their system that are also causing that respiratory depression, or that kind of disconnect between the brain sending signals to the lungs telling. So in about 0.08% of cases, naloxone is not able to reverse the overdose. A little bit more commonly, what we would expect to see are withdrawal symptoms. So these are the customary symptoms that anybody experiences when they undergo opioid withdrawal, except in the case of naloxone, because it's being administered, that's what's called precipitated withdrawal, and it tends to be significantly more uncomfortable than what would be more traditional withdrawal if an antagonist or an opioid blocker like naloxone is not administered. So those withdrawal symptoms include things like nausea, vomiting, diarrhea. Patients will feel very anxious. They may be sweating. Their eyes will be watering. They'll be yawning a lot. And they may feel severe physical pain and cramping all over their body. So this tends to happen in almost 3% of patients. These withdrawal symptoms can be avoided if lower doses of naloxone are given. However, given that we're talking more about community distribution in this setting, we don't recommend trying to mess with or adjust the dose that's being administered. We really just encourage providing the dose that is available in those like branded naloxone nasal spray devices, or any of the other devices that I had shown a little bit earlier. Rarely people may be agitated when they come out of an opioid overdose. I tend to see that these reports seem to happen a bit more as urban legends when certain folks are reporting that they reversed an opioid overdose and then the person beat them up afterwards or something. I've genuinely never heard of that actually happening on a firsthand account. And it is quite rare, but I would be remiss to avoid mentioning it at all, as it is a minor risk. And then another thing that can happen that is also extremely low risk is seizures. And this would be more likely to happen in the case of such severe nausea, vomiting, and diarrhea that a person's electrolytes in their body become imbalanced, which then adjusts their likelihood of having a seizure, especially if they are somebody who has a baseline seizure disorder that would put them at higher risk in the first place. I think it's important that whenever we talk about naloxone, that we make sure to address the common myths that are seen all throughout the typical media that some of us, kind of hear through the grapevine or hear from our friends or family members. And it's important for us to be equipped to know that a lot of these situations are not true and never happen, as well as being able to bust those myths whenever we are presented with this factually inaccurate information, so that we can kind of set the record straight for other people who might have a misunderstanding as well. And so just kind of going down the list, important for everybody to know that there there has never been a link between increased drug use or increased overdose rates when naloxone distribution programs are implemented. And in fact, we tend to see decreased overdose rates and especially decreased overdose death rates, as I had already presented earlier. There are no naloxone resistant opioids. So when we talk about things like fentanyl or carfentanil or other new and exciting, very highly potent opioids that come to the black market, if a substance is an opioid, then it can be overcome by naloxone. If it is a highly potent opioid, that just means we need higher and higher doses of naloxone to overcome it. But there is no such thing as a naloxone resistant opioid. There's also no such thing as developing an immunity to naloxone. So this is the idea that somebody has overdosed many times, has been provided naloxone many times, and at a certain point the naloxone stops working. There's no such thing as that either. That's simply not how our receptors in our body work. And so this isn't a concern. You can give, somebody can be on their 40th overdose and naloxone is still going to work for them. Something else that comes up often, and this is not specific to naloxone, but this is specific to overdose response and emergency response for people using opioids. Fentanyl powder is absolutely impossible to be absorbed through the skin in the way that it is distributed on the street. When people talk about fentanyl being absorbed through the skin, really what they're kind of confusing it with are fentanyl patches, which are a completely different formulation of fentanyl, and they had required $1 billion of pharmaceutical development, research, and development in order to develop these fentanyl patches in order to be able to get the fentanyl to actually pass through the very great barrier that we have called our skin. And they made it possible with those fentanyl patches. But the other thing to keep in mind is that even with a fentanyl patch, just having it on your skin for even a couple minutes is not going to absorb enough fentanyl through your skin to make any sort of dent or cause any problems in the average person. It typically takes hours of somebody having a patch on in order for the fentanyl to actually be absorbed. So why this is important in overdose response is when emergency responders or anybody are afraid that if they were to go into a room with fentanyl being on a table somewhere or being on somebody else's body, and they're afraid to provide naloxone or they're afraid to treat the overdose because they're afraid of absorbing fentanyl through their skin, then the person that they're supposed to be treating is more likely to die. We don't need to be putting on hazmat suits in order to respond to opioid overdoses. This simply is a completely false myth and has probably caused a lot more harm than we would certainly like. So this is an important myth to bust whenever you come across it. Other things that I've tended to see and kind of hear about, some of the media reports will talk about certain members of the community or law enforcement saying that they have given naloxone to themselves. And the fact of the matter is, if you are able to do anything to yourself, including give naloxone to yourself, that means you are not having an opioid overdose, because an opioid overdose involves somebody being completely unresponsive. It's also good not to throw away, I put expired in quotes, expired naloxone, because there have been some stability studies showing that naloxone in any of those 4 formulations I had shown earlier is actually good for at least 10 years. There are no impurities that develop within the containers. Sometimes some very small amount of drug might decay, which means that maybe a person would be administered 98% of the dose instead of 100% of the dose. So certainly it's not like we're out to stock all of our pharmacy shelves with expired naloxone, but it's also important that we don't throw it away because it does still have value. It is important though that, and I think Josh and Megan are going to get to this in a little bit, but storing it within reasonable temperature range and humidity range is also better at keeping it good for a longer period of time. And then the last line I have, naloxone does not make people violent. This goes back to that other risk that I had presented earlier. It just tends to be a very low frequency event that happens, and we shouldn't be afraid to save somebody's life out of fear that they're going to become violent with us, because it's very unlikely that they will. So as we're talking about potentially starting to distribute naloxone from the jails here, or increasing distribution here, I think it will help to look at what some other systems have shown in the rest of the country. In the San Francisco County jail system, they were able to train a third of folks being discharged in, they were able to train a bunch of people in overdose response using naloxone. And of the people who were trained, a third of them had actually reported administering naloxone to revive someone from an opioid overdose, which is telling us that these are exactly the right people who are going to be encountering others at high risk of opioid overdose. And these people could make a very big impact by giving them naloxone. In the LA County jail system, about 7% of inmates had reported witnessing an overdose in the prior 12 months. And 39% of them had said that they would be interested in going through some sort of overdose prevention and response training. And then regarding the Massachusetts Community Overdose Education and Naloxone Distribution program I presented earlier, there were some other interesting outcomes. 7.6% of the participants had reported administering naloxone for an overdose. So these are folks in the community, not specific to a jail system. So they might be less likely to encounter people overdosing from opioids. And yet still almost 8% of them had reported that they had in fact been able to administer naloxone. Interestingly, they showed no differences in clinical outcomes, meaning that there was no difference in lives saved between the folks who underwent a specific education program versus those who didn't. So what that means is we could probably get by with giving very minimal education to people before they're able to get their naloxone, or as they're getting naloxone, and we could safely assume that they will figure out how to use it, or they'll already know how to use it and be able to save lives quickly. We don't need to invest a bunch of time and resources into massive education programs. As I had already mentioned on that previous slide, within this community distribution program, they showed significant declines in overdose deaths in the community, specifically where the distribution occurred throughout Massachusetts. They were able to compare communities that had the education and distribution and then against communities that didn't, and they showed significant differences in the overdose death rates between those two community types. Okay, I think that might be the end of my slides. So
Thank you so much.
I look forward to the Q&A portion.
Thank you, Jessica. That was a really helpful overview. Just to give our attendees some background information on naloxone's effectiveness and safety for use in our criminal legal systems. So I'd like to turn it over to Josh and Megan at the Grand Rapids Red Project. Josh is a recovery coach who navigates care with patients at any stage of change with substance use. His specialty area involves working with participants that had encounters with law enforcement and first responders, or who have been involved with the criminal justice system in some other way. Megan is a program manager at the Red Project who oversees the overdose prevention and response program within 7 counties in West Michigan and co-manages the syringe access and recovery coaching programs offered at the Red Project. She has an educational background in biology, neuroscience, and psychology, and has prior work experience with healthcare systems, law enforcement agencies, and religious organizations. Together, Josh and Megan will share their experiences implementing naloxone distribution programs and offer a multi-level approach for all of our partners here today to consider when either starting or expanding your own naloxone distribution program.
Thank you, Nicole. So these are the key components of our naloxone training. We often discuss more than anything the recognizing an overdose and responding to an overdose. But I think it's important today to focus on the risk factors, particularly tolerance, especially when it comes to individuals in jail, specifically because an individual's tolerance can drop by 50% within 24 to 72 hours. So that affects individuals that are incarcerated greatly because they may only be locked up for, 24 to 72 hours. And then upon release, their tolerance drops by 50% and may think they can go back out and use the same amount that they were using prior to incarceration. And that puts them at a greater risk of overdose.
Next slide, please. So our project, we have our current partnerships with 3 correctional facilities within West Michigan, so Kent County, Ottawa County, and then North Lake. And each correctional facility operates at a different level. So when we think of different levels, we can essentially place each program within 3 different tiers. Next slide, please. So the first tier would be primarily focused around informational resources. So the primary objective would be providing education around overdose prevention and response. So Josh gave us a quick overview of kind of what our education looks like when training participants. We didn't go into depth just due to time constraints, but if any agencies do need any technical assistance with that, feel free to reach out. We're more than happy to provide that. And then also the second objective to providing informational resources is providing accessible resources to access naloxone within the community. So that can be like a local pharmacy or even a community-based organization, and making sure that some of the basic information such as location, hours of operation, phone number are available. And this can be given through brochures, flyers. It can even be given through conversations when building relationships with individuals. Next slide, please. The second tier would be more program targeted. So when we're thinking of handing out naloxone kits in regards to programs within the jail, you can think of essentially working with programs that correctional facilities already have. A lot of these can be more in relation to substance use disorder. This can be delivered in multiple methods, whether it's a one-on-one training through a recovery coach or case manager, can be delivered through video training, whether it's telehealth, even a pre-recorded video training. It can even, I know prior to COVID, with some of our correctional facilities, we were able to do classroom trainings. So that's just a group training. We're able to have a discussion as we know that we can benefit from learning from one another in those trainings. So what naloxone distribution looked like in a program targeted tier would be more whether it's getting directly handed off from the case manager or recovery coach, and or being put into an individual's personal belongings through informed consent that they have knowledge that it's going in there. Next slide, please. And the third tier would be essentially access to all. So the primary objective of this tier would be that everyone within the correctional facility is getting a naloxone rescue kit. Again, method of delivery for this can be just like a one-on-one training. One-on-one trainings, depending on the individual's level of understanding and knowledge of this, can be anywhere between 5 to 15 minutes, or even just a video training, whether it's telehealth or again, just a pre-recorded video. In terms of distribution, in this setting is going to be set primarily on how the flow of operations are in the correctional facility. Next slide, please. So when we think of implementing naloxone distribution within a correctional facility, it's going to depend on a lot of factors. such as resources available, whether it's funding, access to naloxone kits, can even be care programs that the correctional facility offers, can be staffing and the staffing involvement with individuals that are in the correctional facility. It can be even something simple as printing services. And honestly, this list can just go on, which I'm pretty sure why many of you are here today. However, whichever tier a correctional facility is currently at, the ultimate goal would be working towards a tier 3 of having access to all. As we learned from Jessica earlier today, that everyone and anyone's at risk when being released, and so making sure that they're having access to this medication is very important in these situations. Next slide. So some ways that individuals can access naloxone, whether it's correctional facilities, when we're looking at organizations, it can be through MDHHS. They have launched an online portal where organizations can go in and request free naloxone through their website. ADAP is another organization, which is essentially the pharmaceutical company that creates the branded nasal spray, and they offer it at a discounted rate for nonprofit agencies and governmental agencies as well. Barriers to ADAP though can be that there has to be a prescribing physician willing to sign off on the required forms in those situations. And then next, naloxone is more geared as an individual resource, which is a free online service where individuals can essentially request naloxone through mail delivery with a valid address. And this is funded through Vital Strategies, and that is made possible through partnership with Next Distro and the Red Project. Next slide, please.
So when it comes to the storage of naloxone, you just want to avoid direct sunlight and avoid extreme temperatures. So for instance, if it's in your vehicle, you would want to take it inside if it's in that extreme heat or extreme cold. Furthermore, naloxone should be stored in a single cabinet or storage container until it's ready for distribution.
Next slide. So tracking naloxone, it honestly can be adaptable to program reporting needs and requirement. For example, Red Project is a community-based organization, so when we distribute naloxone with the correctional facilities that we work with a prescribing physician where we have a medical history form that is collected prior to the distribution of a naloxone kit. And then report monthly, quarterly, and annually on those numbers. We have facilities that will track based on the number of consent forms that are signed based on the kits that are placed in individuals' personal properties when they are getting a kit, to ensure that their kit is being put in there and that they gave consent for case management to put that in their personal belongings. But other programs can tailor it to their reporting needs, whether it's a simple spreadsheet for tracking those numbers. One thing that's going to be very important as well in terms of tracking is tracking reversals and making sure that there's no negative impacts in reporting those reversals for individuals due to being involved in a overdose situation. Next slide, please. So when we look at the legal status in Michigan, so naloxone is one of the medications that can be prescribed to any individual or organization and administered to another individual, where criminal and civil liability is removed in these situations, both for the prescriber and end users. So it's one of the easiest and safe medications to prescribe, and we need to make it more accessible to community members. So when we think of accessibility, next slide, please. There is the standing order, which Jessica had talked about a little bit, where individuals can go in through registered pharmacies to get a naloxone kit. However, a barrier to this is that it doesn't include community-based organizations. So when we think of community-based organizations, they have to work with a prescribing physician in order to dispense naloxone kits. And this can hinder services and access to these medications to community members that are going to be at a higher risk of being able to respond to these situations. Next slide, please. When we think of even responding to a situation as well, there is protection for end users. So when anyone responds to an overdose situation using naloxone, that person's not held liable for any damages resulting in the administration. So an example of this can be when an individual is responding and there might have been a needle injury if someone's using an intramuscular rescue kit in comparison to a nasal rescue kit, for an example. Next slide, please. Another way of protection as well is that any individual is also protected if they have any type of professional license. So like, for example, licensed social work, when they're responding to a situation that involves an overdose with naloxone, their professional license in that situation is also protected. So when we think of law enforcement in these situations, can you go to the next slide, please? When I think of law enforcement and law enforcement agencies in these situations, they are able to purchase, possess, dispense, and administer naloxone. So in other words, they can have naloxone on site and dispense the naloxone to participants. Naloxone can be even carried and administered by officers as long as they've received training and believe an individual is in an overdose situation. And civil and criminal liability is removed in those situations when responding. Next slide, please.
Okay, and I'll just briefly discuss the Good Samaritan Law in Michigan. So what this breaks down to essentially is it protects anyone that calls 911 that is seeking medical attention in regards to an overdose and the individual that is in an overdose if they have a personal amount of a controlled substance on them. So it's important to have the Good Samaritan Law because it encourages an individual to call 911 in one of these emergencies.
Next slide. And that recaps the Good
same
Samaritan Law further. And the next slide.
Thank you, Josh and Megan. This is Matt Costello from the center, and I'm going to start the question and answer period. And again, just to review some of the things that Nicole had mentioned earlier. If you've joined us on your computer, you can click the raise hand button on your screen if you haven't already done so to indicate that you'd like to ask a question. If you've joined us by phone, only press *9 if you'd like to raise your hand. We will call upon and unmute you in the order that the hands have been raised. Be prepared to ask your questions and please keep it brief so it allows us to get through as many questions as possible. If your question was asked by someone else, please click the lower hand to remove yourself from the queue. If you'd like to ask a question but don't feel comfortable asking it live, you may enter your question in the Q&A box on your screen. We will address the live questions first and then we'll move on to the written questions if we have time. So I have a couple of questions here that have been typed in, so let me start with those a little bit. The first question is jails can be a very busy place with high turnover. Spending even 5 to 15 minutes per jail resident could be burdensome in some jails. Could you discuss having only written instructions as the primary way to train residents in naloxone use? I'm going to think that's probably Josh and Megan maybe.
Yeah, so we do have training materials that are written both in English and Spanish that can be given to participants as well. In those situations, a lot of times when they are given in written, sometimes a quick overview is provided as well. but a lot of times participants are well aware as well and how to respond. We just want to make sure that they are comfortable enough that if they are in a situation, they are knowing how to respond and that they feel comfortable. A lot of times too, with like the nasal kits, for example, they do have pictures that come in the front of the box, as well as some further written information that can be provided as that education too.
Thank you. Perfect. Jessica, I think this question might be for you. Is there any population that naloxone might not be indicated for, even if they're opiate involved? Is there any contraindications, I guess would be the way of putting it?
There basically aren't any contraindications. So the only one would be an allergy to naloxone, which is, I've never encountered anybody who has an allergy to naloxone. So the nice thing about naloxone is even if somebody has something else going on and you don't know what it is, let's say they have low blood sugar and they pass out. If you were to give them naloxone, it's not going to hurt them. It's not going to make their blood sugar go lower. It actually does nothing. Like, I used to work with a social worker actually who would train people on naloxone, and she would actually administer it to herself while she was training people on naloxone, just to show that it really doesn't do anything to you if you do not have a physiological dependence on opioids.
Right. You mentioned before about people with seizure disorders. Would that still, the benefit far outweighs the risks, right?
Yes, we know how to treat seizures. We can't treat somebody who's dead.
Yeah.
So, you know, we want to be able to save that life. It's absolutely not a contraindication to administering naloxone.
Perfect. Thank you. Appreciate that. The next question here is, again, I think it's been asked, but I think it's always a good one to revisit. If I give naloxone kit and it doesn't work when they overdose, will I be held liable if their overdose results in a death? You guys are all on mute. So.
No. No, that's what the Samaritan laws specifically are for.
Okay. All right. Jessica, when you talk about the naloxone kit, where is that actually injected? Is that an intramuscular IM medication also?
Great question. So there are, I said there were those 4 different versions. There's the one that is the Narcan nasal spray, which is that branded product. Kind of obviously looks like it goes right into a nostril, and then the plunger is pushed, and that's all you have to do for that one. Requires basically no education. The one that is the kit with those like peach boxes, so that's actually also administered into the nose. There are a couple more steps that are involved in that one. So that is the one that tends to require a little bit more education. I've worked with patients who felt more comfortable with it when they practiced with it a few times, because I've had other people say that the vial's broken while they were trying to administer it to somebody. It is one of the cheaper options available to us, so that tends to be why it is still involved in these community distribution programs, but it does have some drawbacks in that it does involve more steps in order to get it into a usable form.
Thank you. Next question, I'm sorry. Law enforcement officers sometimes find themselves administering naloxone to the same person over multiple separate instances. Does providing naloxone encourage people to continue to use them because they know naloxone will be there to save them? I think I'll turn this to Red Project for Josh and Megan.
No, because from speaking from personal experience, and I know Jessica mentioned this briefly as well, individuals who use, particularly an individual who uses every day that's an active addiction, when they have Narcan administered to them, can go into a withdrawal. And speaking from personal experience, it sucks. So it is not something that anybody is just going to say, well, you know what, I can use every day and use to excess because there's always Narcan. No one is looking to get Narcan. At the very least, it's going to get rid of their high, and they're going to have to go out, get more money, and get more opiates again. So no, I would say no to that.
This is a kind of,
oh, sorry.
Yeah,
can I
go
just
ahead,
kind of
Jessica.
tack on to that too? I just wanted to really underscore the fact that they've done research on this, and it has never been shown to have a link between increased community distribution of naloxone and increased drug use. It doesn't happen.
Just maybe a little bit of a follow-up to that question. So an individual in the community is administered Narcan. How long is that Narcan effect in place? So, you know, if the person doesn't go to the hospital or whatever, just how long is that effect in effect?
So each dose of naloxone, once it's administered, is active in the body for about 30 to 90 minutes. And that depends on the amount of opioids that were in the body before the naloxone was administered, and the potency of those opioids and the duration of action of those opioids, but somewhere between 30 and 90 minutes. And for this reason is why there are always 2 doses dispensed at one time. So in any naloxone kit, there are always 2 doses. And that is because there is a chance that somebody can actually slip back into an overdose after they've been revived, and they may need another dose administered.
It kind of goes to this next question a little bit, but how does a person who's administered a dose of naloxone to somebody determine whether or not a second dose is necessary, or more, even if more are necessary? It could be more than 2, I guess.
Sure. You're looking for responsiveness. So when somebody is overdosing, they look like they're dying. Their lips are turning blue, their fingertips are turning blue. They have no oxygen coming into their body whatsoever, and they're completely unresponsive to any sort of jostling them, you know, trying to, you know, tap their face, like kind of slap their face a little bit lightly, not hard, anything like that. They will not respond. And so administering naloxone, if it makes them responsive, that means that the opioid overdose has been reversed. But like I said, there is that risk of the overdose coming back, depending on those opioids that are still in the system. If the person does not respond after 2 to 3 minutes after the dose of naloxone has been administered, then we say to give another dose. And remember how I said there's no such thing as an opioid, or I'm sorry, naloxone resistant opioid. So this means that some people will require multiple doses over and over again of naloxone, depending on what was in their system and the potency of the opioid that was in their system. At a previous job I had, we had a patient who had overdosed in a bathroom at one of our clinics and required 11 doses of naloxone, but revived and lived. Right. So the overdoses can be reversed. It's just that we need more and more naloxone, especially if it is individually an opioid that is causing the overdose.
And I just want to briefly highlight the point that you made in regards to 2 to 3 minutes, because I mean, we've all seen Pulp Fiction where it's an adrenaline rush to the heart and they immediately pop right up out of that overdose situation. So I just want to highlight, it's not always or necessarily going to be immediate as soon as you administer the Narcan to an individual. They might not pop right up like you would see in a movie. It's, you know, give it 2 to 3 minutes, provide rescue breathing, and go from there, and then administer another dose after 2 to 3 minutes if they're still unresponsive.
So there is a correlation between the opioid used and the possible responsiveness to Narcan. So when we've seen these fentanyl usage being elevated or starting to be used more frequently, maybe unknowingly, it might not be unusual to expect to use more than a dose of Narcan.
Yep, usually the doses, the 4 milligram doses that are what are in the nasal spray devices, that's a pretty hefty dose of naloxone, and it will reverse most overdoses. It's that other version of that nasal syringe kit version that tends to just sometimes have a little bit of a slower or not as effective response, because there's actually a very high volume of liquid that you're spraying into somebody's nose, and a lot of it kind of dribbles back out of their nose, and so they're getting that full dose that you're trying to administer.
Okay. To Megan and Josh, can you share with an example of the form that you're using to track your naloxone distribution? And a second part to that, does the individual have to pay for a naloxone if they request it from a pharmacy?
Can you repeat the question one more time?
Yeah, absolutely. It's a two-parter, so I'll just go with the first part first. Can you share an example? I think you were talking before of tracking naloxone distribution. How is it you're tracking the distribution?
Yeah, so we track them through primarily medical forms that we have. It's one sheet, it's one-sided, They're very simple questions. We try to make it very short and to the point. The very basic questions that our prescribing physician would like to have answered with a signature on it. So we track our naloxone distribution primarily through that way of format in terms of that right now.
Okay. The second part of the question, and again, it could go to either one of you, we were talking, you were mentioning earlier that a pharmacist at a local pharmacy can write the prescription and fill the prescription themselves. Does an individual who goes to a pharmacy for that and to request it have to pay for that Narcan, or is it a free medication to them?
No, so when naloxone is acquired through a pharmacy, then the payment is required. So it's either an out-of-pocket cash payment, which can be quite high, and I don't recommend that, or their insurance can be billed. And depending on their insurance, that can also be kind of a high out-of-pocket cost. So for most of the people that at least I encounter, I usually actually recommend the community distribution programs where folks can get it for free.
And that was the material, I think, that Megan and Josh kind of showed the different communities or agencies that are stepping into that void to help those kinds of barriers. Are local farmers required to stock Narcan? Is that something that they have to have on, or they can?
The state of Michigan doesn't require it.
Yeah, I'm not sure how those pharmacy rules work, kind of thing. So I would, yeah, any which way. So I'm not sure. That's all the questions I have at this point. Do you guys, were there questions that weren't asked that you're saying, why isn't anybody asking about this? Because they really need to know about this. Maybe Jessica, I'll start with you and then go to Megan and Josh. Anything that we didn't ask about that is important for us to remember about this? Because it'd be great to hear it from you guys.
Gosh, I didn't think that far in advance. No, I can't think of anything. But I can also, my email is on the slides, and I'd be more than happy to answer any follow-up questions or anything that anybody thinks about after they sign off today.
Very good.
Yeah, we're in the same boat as Jessica. I can share if you guys need any follow-up questions answered, but I think we covered a lot of the material of what we would like to be addressed through our presentations.
Well, I have to agree with that 100%. I was trying to think of questions in the next slide. There was the answer. Then, I got another one. There was the answer. So a sign of a very well-prepared presentation. So I really appreciate your guys offering that expertise up. And I'll turn it over to Nicole to kind of any closing comments and go forward. But again, the center wants to thank you guys very much for giving of your time on this important and critical kind of a service that's out there and that needs to be out there even more, right? So Nicole, I'll turn it over to you.
Thank you, Matt. And yeah, thank you, Jessica, Josh, and Megan for your participation today. And thanks to all of you who are joining us virtually for this event. We will have a recording of this webinar posted on the CBHJ website and our YouTube page within the next week or so. And we'll also send out a copy of the slides and any related materials to everyone who registered for this event as soon as we can. Definitely keep an eye out for future events in this series. These webinars are going to be held every other month. So our next one will be in October. And we're also in the process of sending out invitations for our OTE Summit, which will be in September. So keep an eye out for both of those things. And last but certainly not least, we really value any feedback that you have about these events. It's important to us that the content that we share is useful and relevant to the work that you're doing in your communities. So if you have any feedback, we do have a survey that will pop up on your screen once we end the event today. And if you could just take a moment to fill that out, we would greatly appreciate that. Thanks again, everyone, for joining us today, and we'll talk to you soon.